a resubmission, and the notice of award came in on May 1st, and it's almost July 1st somehow, and it's just getting started. I don't know if that's normal or if I'm behind already, but I say that to say I'm presenting not results or any preliminary findings, but really just my aims at a really good time to get feedback, based on reviewer feedback. I had revised the initial submission, but now that I'm actually starting and I have the grant, I would love to continue to incorporate feedback across all three aims. So just to give you a little bit of background, I think, about me and kind of my training and my motivations to doing this work. I did my emergency medicine residency in Philadelphia at the University of Pennsylvania. And like much of the country, but in a very unique way, Philadelphia has been the epicenter of the overdose crisis. And it was really kind of my exposure through my clinical shifts, taking care of multiple young people who had succumbed to an overdose in the emergency department, telling multiple mothers and fathers that their young child had unfortunately died of an overdose. And having mentors who had thought a lot about this problem and this crisis, and kind of learning through them, both inside the emergency department, but actually more notably outside. I volunteered at Prevention Point Philadelphia, which is a harm reduction syringe exchange program, and really learned so much more about taking care of people who use drugs through those experiences. After my emergency medicine residency program, I stayed at the University of Pennsylvania to do a fellowship through the National Clinician Scholars Program, and got a master's in health policy research, and started to gain skills on research methods, and conducted some secondary data analysis projects around substance use disorder, Medicaid expansion, some qualitative work. And then in 2021, I joined the faculty at Mount Sinai. My clinical time is split between Mount Sinai Hospital and Elmhurst Hospital, which is part of the health and hospital system, the public hospital system of New York City. And I mention that because that hospital actually receives patients from Rikers, the largest jail system in New York City. And so I frequently take care of people who are currently incarcerated at Rikers, or who had recently been discharged and access healthcare in the emergency department as their initial point of contact. And then I mentioned I'm also an alum of the CGRT program. And then I'm currently on the board of directors and the co-chair of the ACCJH research committee. And I know there's a lot of overlap between these organizations and folks on the call. So I just wanted to mention that. I'm not going to give a lot of background, especially to this group, but I just mentioned that my research interests within health services research are at the intersection between addiction and incarceration. And I'm really interested in how to improve healthcare access and outcomes for this population. So this was a modified conceptual model that I included in the background section of my K-23 application. And it really tries to start to understand the multiple characteristics and factors that influence the health outcomes of people who have opioid use disorder and history of incarceration. And we know that there are contextual characteristics that can be predisposing or enabling. We know that there are individual characteristics, and then both of these together influence health behaviors, whether that's where people utilize healthcare services, whether that's the use of drugs and alcohol, or notably for my project, the health behavior I'm interested in is engagement in opioid use disorder treatment. And ultimately, the goal is always to improve outcomes, whether that's health general health or more specifically, reducing overdose mortality. So this is my K23 application in a picture. These are the 3 separate aims, which we'll go through each in more detail, but kind of just the big overview. My first aim uses observational data to define the current state of post-release treatment engagement in New York City. The second aim uses qualitative methods to try and understand, how a telebuprenorphine clinical protocol may be adapted to this population during the point of reentry. And then the third aim is a pilot randomized control trial that looks at acceptability and feasibility outcomes primarily on telebuprenorphine post-release from jail versus standard of care, which is referrals to clinics in the area currently in New York City. My mentorship team is diverse, both in location and expertise. My primary mentor, Dr. Lynn Richardson, she's the director of the Institute for Health Equity Research at Mount Sinai. And she is an expert on disparities in equity, primarily in emergency care, but in other health conditions as well. Dr. Tyler Winkleman is at Hennepin County Healthcare, and he's addiction medicine, also spends his clinical time at Hennepin County Jail. Dr. Josh Lee is also addiction medicine. His parent R01 is where the data set for my AIM-1 is coming from. And he has done a lot of work with correctional health services within Rikers. And then I don't think Dr. Brennan Marshall needs any introduction in this group, but I was first introduced to him through the CJRT, and I'm really lucky to continue to be able to work with him. And then my K team also includes an advisory board. So on the advisory board is Dr. Ronald Day, who leads the Fortune Society, which is one of the biggest and definitely the oldest reentry-based organization in New York City. Dr. Day is formerly incarcerated himself, but has really grown the organization's scope and mission over the last couple of decades. Also on my advisory board is Dr. Bipin Subedi, who's the Chief Medical Officer of Correctional Health Services at Rikers. And then lastly, a colleague who I've worked with for a long time. I first met during residency, but Nicole O'Donnell is a certified peer recovery specialist based out of Penn. So for AIM-1, I mentioned that this data set comes from an existing R01 that Dr. Lee has with Dr. Lim and McDonald's. And this was a R01 that looked to integrate data sources from correctional health services, Medicaid, and EHR data. It's admittedly a little bit old at this point where I'm just starting my K that was written now a couple years ago initially. So it includes all jail admissions from 2011 to 2017, and they've expanded to 2018 as well. The cohort includes all individuals who screen positive for opioid use disorder. And then they are further stratified into whether they received treatment during their incarceration. These were the outcomes of the parent grant. And so what I proposed to look at was whether the primary exposure of receiving buprenorphine during incarceration is associated with treatment linkage within the first 2 weeks of release from jail. And this would be identified through Medicaid claims data and defined as having both an outpatient opioid use disorder treatment encounter as well as a prescription for buprenorphine. And I'm interested in understanding characteristics, both individual level characteristics, whether they're demographic or clinical, as well as correctional or carceral factors, such as the type of charge, the duration of incarceration, the release date that might be associated with positive treatment linkage. And really the goal of this is to then, based on who we know is more likely to access treatment linkage within 2 weeks of release, to be able to identify who we're missing currently with the usual standard of care. And that would be who I would target the telebuprenorphine intervention on. Since this was submitted and since I found out that it was funded, I've also discovered an alternative data set that I could use to either supplement the initial AIM-1 or perhaps combine. This is through the Minnesota EHR Consortium, which actually Dr. Winkleman, one of my co-mentor, leads. But it's a state-run, statewide initiative to link EHR data. And as a result, and they also link with the county jail system. So as a result, you can do a very similar type of analysis, looking at both correctional factors as well as healthcare utilization. Obviously, it's a completely different location, separate from where my intervention would be taking place. The benefit of this is kind of talking about the considerations of the two data sets, but the benefit of this data set compared to the one I had initially proposed using was that it's more recent. And so because we know advances in telehealth occurred largely after the pandemic, that the overdose crisis and kind of treatment availability has changed since 2018, which is the end of the New York-based data set. And because it's a different population, I thought, it would be interesting to think about ways to compare the two cohorts. I think there's a lot to think about, but I just heard about this data set and I thought this would be a good group to kind of get feedback on kind of changing the initial AIM-1 as it was submitted. The second AIM, the qualitative AIM, really uses this methodology of intervention mapping, which is often used to include both theory and stakeholder involvement in the development of behavioral change interventions, which is what I consider my intervention to be. And so there are 6 different steps, but the qualitative AIM that we'll talk about in a second would really address kind of the needs assessment and the specification of the program objectives. And so because a lot of the clinics in New York City and across the country were using telehealth during the early months to years of the COVID pandemic, this AIM really seeks to learn from that experience by speaking with both people who have opioid use disorder and a history of incarceration who did use telehealth services for buprenorphine treatment, as well as clinicians and correctional health staff and leadership who implemented these programs to understand kind of the acceptability and appropriateness of the intervention in this population, some contextual issues that might have come up for either the patients or the clinicians with a novel way of delivering addiction treatment, and then some organizational and logistical considerations that would be important to understand before actually developing the clinical protocol. And so then in between AIMs 2 and 3 would be the development of the clinical protocol, really the first visit, what the visit would entail, what the follow-up would be, how much buprenorphine would be prescribed, for how long, what kind of the referral from that linkage would be. So once that protocol is developed, largely informed by AIMs 1 and 2, I would conduct a pilot RCT comparing folks who are either randomized into a telebuprenorphine initial appointment versus just standard in-person community linkage. These are a few more details on how I conceptualize the pilot RCT. So it's a small sample, kind of within feasibility of a modest K budget, but 25 in each arm. Pretty standard inclusion and exclusion criteria. Notably, I did want to exclude people who are already engaged in treatment in the community, and really focus on like fresh starts, fresh linkages in the community. And then right now, as it's written, the recruitment is post-release from Rikers. That was mainly because I couldn't get the DOC and Correctional Health Services to kind of sign off on pre-release consent and enrollment prior to the grant being funded. That is, I am able to readdress that in a couple years when this would be taking place. But right now, as it's planned, it would be release consent and enrollment post-release. And there are a couple different ways that that could be done. There is a pretty organized and extensive program within the Correctional Health Services that helps people during reentry, including a phone line and a dedicated case manager. And so referral through those sources to the study. There are a couple of community-based organizations, including Fortune Society, which I mentioned, that would be places for recruitment. And then there's also like a physical trailer where folks, after they're released from Rikers, before they get on the bus to be dropped off, often check in for different things. And technically that is post-release, and that would be another place for potential recruitment. Because this is a acceptability and feasibility study, these are the outcomes that I'm looking at. So kind of standard feasibility outcomes: recruitment rate, enrollment rate, adherence rate, study retention rate, and attrition rate. And then for the acceptability, either by the patient or the clinician, they're validated surveys that have been used on telehealth, and actually a new one regarding telemedicine for opioid use disorder. And then all of the efficacy outcomes would be just preliminary, as we would not be powered to detect a difference. Because this is a K-23, I think the training aims and the training development plan is just as important as the proposed research study. So I just wanted to share those briefly, just to get some feedback on opportunities or experiences that this group may be aware of that I wasn't when I wrote the application. Most notably for my first training aim, which is to develop advanced knowledge of correctional health care and addiction treatment and care transitions during reentry. The second training aim is to acquire more advanced quantitative skills, particularly for linked data sets that involve both clinical and administrative data, namely with linking health records with correctional records. Definitely will require a lot of training on the design and conduct of clinical trials, which I have not done previously, especially on marginalized groups, and then just additional training on grant writing and grant management. These are some of the things that I have in my my first training objective. Some resources that I found and was told about. JCoin has a lot of really interesting lectures that I've already started that's available. ASAM also had a course on corrections, telehealth, and opioid use disorder. I'm also going to be spending some time observing the both clinical and administrative operations at Rikers within correctional health, as well as hopefully in Hennepin County. And then there's some funded groups that I'm a part of and will continue to participate in. But really interested in that's kind of all I have to share. But these are just some, I would really love any general feedback and advice, but looking also specifically for additional trainings or resources around the first training aim, specific courses that may be available virtually online on data set linkage and causal analysis, coursework on clinical trials, and then any workshops or boot camps on project management. That is all I have. I will stop sharing so I can see the screen. But really, like I said, just starting. So really great time to get feedback and make sure I